Good morning, everyone. Today, we're going to discuss a little bit about our processes at Avesta in order for you to become a patient. So, we'll start right at the top. What happens during your initial consultation? Well, when you call into Avesta and you're interested in one of our services, we will schedule a free phone consultation with one of our intake coordinators. And what generally happens is we first ask some questions. We want to make sure that you have an official diagnosis made by a healthcare provider, that you have one of the diagnoses for which we believe ketamine works based on evidence, based on the research that's out there. And also to make sure that you do not have any medical conditions that would preclude you from receiving ketamine. So let me give you some examples. So, for example, patients who have a history of schizophrenia or schizotype disorders, patients who are in the hypomanic or manic phase of bipolar, and then patients who've had history of severe psychosis we believe, are not good candidates to receive ketamine because of its dissociative effects. And so, we first want to make sure that you have a diagnosis made by a professional and that diagnosis aligns with the research out there for demonstrating that ketamine works for your specific diagnosis. So that would include uh, major depressive disorder, suicidality, PTSD, anxiety, depression, uh, OCD. So we just want to make sure that you have one of those diagnoses for which now there are some clinical studies, as opposed to those that A, there are no studies, and B, we believe that because of the dissociative effects, it might actually not be a great idea to get ketamine, whether it's the nasal or the IV. So that's how we determine if you are a good candidate, that you have a official diagnosis and that diagnosis aligns with the evidence for which ketamine would be useful in your specific diagnosis. And then we do ask a lot about your medical history. We want to make sure that you have no uncontrolled underlying medical conditions. So, for example, you can certainly get ketamine if you have a history of high blood pressure, but we just want to make sure your blood pressure is under control, that you're taking medication for it, and that medication actually is working for you. So, we want to make sure that with your cardiovascular system, with your liver, your GI, your kidneys, we want to make sure that everything is in order before we come along and add a medication to your regimen. So as far as the structure of the IV ketamine infusions, and we'll talk about IV and Spravato a little bit differently. So the IV infusions basically do those in two phases. The first phase is the induction phase, where we really kind of want to come at those receptors very intently. So what we do is we have you come in twice a week for 3 weeks for a total of 6 treatments done in very quick succession. We don't want to step away from those receptors for long periods. And so that's why the cadence usually works twice a week for 3 weeks. Now, if you're in town and you're coming from a long distance and you want to get those in within 11, 12 days, we can do that as well. In fact, our clinical study that we concluded last year that we published was done thrice a week for 2 weeks instead of twice a week for 3 weeks. So we can certainly do it that way as well. Either way works. Research has been done on both protocols, and they both seem to have similar results. So, generally speaking, though, with people's work schedules and everything, it makes more sense to do twice a week for 3 weeks. And then once you're done with that induction phase, and by being done means that you're starting to feel less anxious, more functional, less depressed. Once you start to feel a little bit better, more responsive to the treatment, and you've achieved your goal, then what we do is we go to a second phase, which is the maintenance phase. And during the maintenance phase, our goal is to start tapering you off the ketamine. So, in other words, you've been coming twice a week. Instead of twice a week, we might have you come once the following week. Or if you're doing really well, we have you skip a week and come once, 2 weeks out. And if that works well for you, then we'll try that for a month. And then from there, we'll go to once every 3 or 4 weeks. And then if you do well with that, we go to monthly. I do like people to stay on a monthly regimen because I do want to keep coming at those receptors and engaging them, every month for a couple of months, 2, 3 months. And we just keep assessing. The staff will talk to you. We'll gather information on how you're doing. We do deploy surveys, that are reliable, statistically reliable, and have been validated, such as the PHQ-9, the BDI-2. So we'll deploy surveys as well, and as long as you're doing better and better and doing well with coming in less and less frequently, then we'll slowly taper you off. So, in my experience, having done this for 7 years now, we find that when we taper patients off slowly, that they do better and better. In other words, that way there's no backsliding where people feel like, oh my God, I did the 6, I was doing great, and then 2 months later I have to come back now. So rather than doing it that way, we like to keep those receptors engaged to really build on the neuroplasticity. And then, of course, as you're feeling better, we do start talking about the importance of exercise and diet to keep the momentum. Because now that you have these new neuronal connections in your brain, we want you to keep them healthy. And the best way to do that is by exercise. And you can start slow if you're not a regular exerciser. That's okay. You can start with just walking. I always tell patients, everyone likes some kind of music. Just put on some music, dance for 5 minutes in your hallway. And then if, a week or two later, try it for 10 minutes and then try it for 20 minutes. And before you know it, you've built a daily habit of movement. We really want people moving. To me, as a physiologist, movement is medicine. And if you're not moving, you're going to start losing those neurons. And then the other aspect, really important aspect, is vitamin-rich diet that has complex carbohydrates as well as rich in protein. So, the proteins, complex carbohydrates, and, vitamin-rich food will really help sustain those new neurons and connections that we've built. But we also recognize that, when people are depressed or not functional or super anxious, we don't, that's not a good time to talk to them about, diet and exercise and all of that. So it's after the patient's been through the induction phase that we start talking about, in the maintenance phase, okay, now we're going to slowly taper you off. And the way that you can help us physiologically is by maintaining a healthy lifestyle. And then the other thing we highly encourage people to do is continue to work with their therapist to help them integrate, the new changes. People become a lot more available to their providers in incorporating, the suggestions, the coping mechanisms, the appropriate reactions. So we, alongside the diet and exercise, we do recommend that as you're going to maintenance phase and continuing to come less and less frequently, that you continue your psychotherapy for as long as you and your therapist feel it necessary. So one of the questions we get asked a lot too on the intake is, tell me the difference between IV and Spravato. Well, the Spravato is just the S enantiomer of the IV ketamine, which is R and S enantiomers mixed equally in the bottle. And the biggest difference is that in 2019, the FDA approved the Spravato or the S enantiomer specifically for patients with major depressive disorder or patients who have suicidality that are adults. So if you're an adult that has that diagnosis and you've failed a couple of drug regimen, then we can usually prescribe Spravato and have you do that regimen. That's similar to the IV, but a little bit different. So the difference is that with the IV, you're coming twice a week for 3 weeks. With the nasal, you come twice a week for 4 weeks. It's not as bioavailable as the IV. When I give you a medication IV, you're getting 100% of it. When I'm giving it to you nasal, you're probably getting 30%, 40%. So it's not as effective necessarily, or you're not getting as much of it. And the IV is both the R and S enantiomers, whereas the Spravato is just the S enantiomer. And so that's another difference. And then in terms of the treatment itself, we have to monitor you for 2 hours with the nasal. That is a requirement of the FDA when they approve the drug. For those of us that prescribe it and administer it in the clinic, we have to monitor you for 2 hours. So the treatment is 2 hours long, twice a week for 4 weeks. So for a total of 8 treatments, that's the induction. And then we do it once a week for another 4 weeks, and then we taper off from there. So it's a little bit more stringent, the dosing guidelines, because it's specifically FDA approved for major depressive disorder. And they want us to provide the medication administered exactly in that way. So as far as, okay, I'm done with the intake, I'm ready, I'm coming in. What should I expect the first treatment? Well, the first treatment begins with you being shown to a very comfortable private room. Once you're in the room, we make sure that you have a heated blanket, that you have an eye mask if you didn't bring one with you, that you have noise canceling headset. And then once you are comfortable, we check your vital signs, and the nurse practitioner will come in with you. They will talk through your intentions for the treatment for the day. And then they start the IV or observe you instilling the nasal Spravato if you're doing Spravato. Once you've begun the treatment, you basically lay back, relax, you listen to your own music that you've brought, a good ketamine playlist, hopefully, and just relax. We check in on you intermittently. We try not to disturb patients, but we are monitoring you. We're watching over you. And if you need anything, there is a buzzer in every single room. You can buzz us and we'll be there in a couple minutes. All the clinics are very small. And then once the treatment is completed, we come in. The nurse practitioner, if you have an IV, will remove your IV, or the medical assistant will remove it. We'll check your vital signs, and then we'll sit with you and help you start to integrate what you experience so that we know how to manage your dose for the next time, but also to help you begin to think about the things that came up so that you can bring it back to your therapist for integration that week. Research has shown that the best time to integrate your experience is a day or two later, but we do like for you to anchor the thoughts and ideas that came up so that you don't forget them. So that's what we do. And then once we've done that and your vital signs are stable and you're fully recovered, then you may leave, but you can't drive. So you either have to have someone pick you up. That's our preference. But if you're fully recovered, then it's okay to catch an Uber or Lyft or a taxi. So that's basically what you would experience in terms of your first session, and actually all the subsequent sessions as well. I think another thing that comes up a lot, or another very good question that comes up, is what are the side effects of ketamine? Well, the main side effect is nausea and vomiting. And so because of that, we tell patients to follow an anesthesia protocol where we ask that you not eat anything for 6 hours and you don't drink any fluids for 2 hours before coming into the clinic. That really will help cut down on the nausea. And then we do give patients Zofran. If you're getting nasal Spravato, we give you oral Zofran. If you're getting IV ketamine, we give you IV Zofran. And between the anesthesia protocol for not eating and drinking and the Zofran, we usually don't have any issues with nausea and vomiting. So we can really mitigate that before we even begin the ketamine. But if that doesn't work, we do have other medications that we can provide. But generally speaking, those two in combination will work. The other side effect of ketamine is a transient increase in blood pressure and heart rate. It's that the medication activates your fight or flight internally, kind of turns on the sympathetic nervous system. And so because of that, patients do experience a temporary increase in heart rate and blood pressure, but not to a degree that is ever concerning. We have medications to treat it. But quite honestly, having done this for, 8 years, I don't think we've ever treated. Maybe once we've had to treat someone's blood pressure and then told them, hey, you need to make sure with your primary care or your cardiologist that your blood pressure is better controlled before you come in next time. But generally speaking, it's transient, it's not an issue, and it doesn't go so high that we get concerned. So those are the two main side effects of the ketamine. A third side effect is its dissociative effect, which actually is what a lot of people want to experience. And that is the feeling of dissociation where you feel outside of your body and your mind as well. And then the last thing I'll say about the treatments and our unique, the unique reason to come to Avesta, I think, is what makes us extremely special, is that we almost act like a caseworker for you in that we do coordinate care. So within the first week or two that you come to the clinic, if you were referred to us, we immediately contact your provider that referred you. We start talking about what are some of the things we should be aware of. We tell them how we think you're doing as well. But if you were not referred, you self-referred, or you were referred by your primary and you want us to coordinate care with your psychiatrist or psychologist, then what we do, or your therapist, what we do is we ask your permission, your written permission to reach out. And we endeavor to 100% of the time reach out to your other mental health providers because we believe it really is the Avesta philosophy that if we can coordinate care with the rest of the team, the rest of your mental health team, then you will get better outcomes. And research has shown that time and time again in various settings. And we believe applying that to our setting, to our mental health care for our patients really makes sense. So once you are an Avesta patient and you've been through all the processes that I just mentioned, we do start to coordinate care with your other healthcare providers. So a good example is just yesterday, I had a phone conversation with a provider who mentioned that her patient had done really, really well, had really good benefits, but they were starting to feel like they were backsliding. When I pulled up the patient's record, I realized that the patient had come in for an induction phase. They did that. They completed that. And then they did not come back for almost a month. And then they came back once, felt well enough after that. And then they didn't come back again. And now it's been almost 5 weeks. So what I described to the provider was that we have a certain protocol for induction and then taking patients to maintenance. And if patients don't do it that way, research has shown, and we've observed, that the ketamine may not stick. It may not work as well. Now, there are the unique patients that do the initial induction, have a couple boosters, and do great. But most patients need to be tapered off much slower. And so when I talked to the provider, we kind of came up with a treatment plan of how to get the patient back in and how to work with them and with her to make sure that we are tapering off appropriately. So that's all I have for today, and I'd love to open it up for questions. Thank you.